Okay, so I think the beeping has somewhat ceased or is less frequent, and my apologies about that beeping. That's actually people logging in to the presentation. Again, my name is Josue, and I'm with the California Endowment. Welcome, everyone. And I went ahead and provided this first page to kind of indicate to everybody how the presentation is going to proceed. We're going to go ahead and provide an update on comprehensive immigration reform, as well as a specific focus on health components of the bill. And then we'll open it up for Q&A for that section, and then we will proceed with the remaining initial proposal, spearheaded by Anthony Wright, Ronald Coleman, Chad Silva, and potentially Vanessa Kahina. I'll let my colleagues introduce themselves at this point. Yeah, so if Sono, maybe you can kick us off, please.
Hi, can you hear me?
Yes.
Do you want me to introduce myself, or you want me to start? Sorry.
No, well, let's start with introductions, and
Okay.
give folks a moment to write down everybody's contact information, and then we'll proceed.
Okay, great. Well, thank you to the endowment for putting this webinar together, inviting this great group of panelists. My name is Sonal Ambigaonkar. I'm the health policy attorney at the National Immigration Law Center. I work out of the LA office, our headquarters, and I concentrate on health care, and so I'm not an immigration attorney, but I'm happy to try to answer your immigration questions. And so I look forward to presenting.
Good afternoon, everybody. My name is Angelica Salas. I'm the director of the Coalition for Humane Immigrant Rights of Los Angeles, better known as CHIRLA. And CHIRLA is an immigrant rights organization that is working on immigration reform, but also directly organizes immigrants and their families on various issues, including health care, and seeks to educate immigrants about access to health care and opportunities that they can have in order to ensure the well-being of their families. We pay special attention to exclusions of immigrants in these policies, and seek to also advocate so that they have access, like everybody else, to some of the most important health benefits available to them.
Hi, this is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. Really pleased to talk about a proposal that we work with several allied organizations on to try to make sure that there is care and coverage for the remaining uninsured as part of the big fight that we're in right now with regard to the Affordable Care Act implementation, Medi-Cal expansion, and the debate over the dollars for the county safety net. I'll talk more about that in the second half of the presentation.
Okay, well, Chad Silva, Policy Director for Latino Coalition for Healthy California, and I'll just be commenting mostly on how this is affecting, again, the Latino population, but also with respect to a little more specifics on some of the effects on the safety net, particularly the clinics.
This is Ronald Coleman from the California Immigrant Policy Center. I'm going to focus on some facts on coverage for immigrants in California now, and talk about some coverage that's available under the ACA and why the remaining uninsured proposal is important.
Wonderful. So I think that's everybody that's on the line. They introduced themselves, and right before we proceed, I just want to do some minor housekeeping things. So just for those who are attending, the format that we're going to follow, first we're going to follow comprehensive, we're going to go over comprehensive immigration reform with health updates from Sono and Angelica Salas, and if at any point during the presentation you have any questions, please utilize the Q&A box located in the toolbar, and please direct them to me. If you can, please state what organization you're with and to which panelist your question is directed to. Please note that the presentation will be recorded, and I'll go ahead and send the recording of the presentation as well as any additional materials and potentially answers to any questions that don't get answered after the presentation is over. So with that, I think we'll go ahead and pass it to Sonal. And just, yeah, thank you.
Hi, everybody. Can you hear me okay, Jose? Just checking volume. Okay. Well, thank you again. I have a very short presentation because I want to make sure we have time for discussion. I'm going to sort of share in broad strokes what's in the current immigration reform bill that's being discussed in the Senate and sort of the overall provisions, and then focus specifically on what access to health care will look like for those who are on the road to citizenship. And then I will turn it over to Angelica for more of a bigger, broader perspective and what we should do next. So, Jose, next slide. So currently the media and a lot of the attention has been focused on the Senate, in the U.S. Senate. The bill that everyone's looking at right now got introduced back in April, and it's from the Gang of Eight, which is four Republicans and 4 Democrat senators worked together to create this bill, and it went through just recently the Senate Judiciary Committee for the last 3 weeks, and it just passed actually last night out of committee, 13-5, so it's on its way to the floor. And in order to make it out of the Senate, we're going to need a minimum of 60 votes. And Angelica can give you more of the politics behind all of that. And in the House, there's been a lot of recent media attention on that there's not an official bill yet in the House. There's also a smaller gang of 8 a bipartisan gang working on the bill. And from recent media reports in the last couple of days, it's sort of out there now that the access to health care that would be provided to immigrants under this bill in the House has now become front and center of sort of the debate right now. And I think in the House there's a lot of concern that for the Tea Party folks that are in the House that they do not want a road to citizenship for immigrants because they consider that amnesty, and the Senate bill does provide actually a road to citizenship. So that probably is the better bill depending on what we see out of the House right now. Next slide. So there's lots of stuff in the 844 pages of the Senate bill, which is, I'm just going to refer to it as Senate Bill 744. I'm picking out just the very, very big pieces, and immigration folks will have more of the details, and there's a lot of stuff on border enforcement that I haven't included here, but I wanted to focus us on sort of how the bill provides legalization paths to folks and some of the other bigger pieces. So as I mentioned, the Senate bill does have a road to citizenship, which is an actual path that you can take to actually become a citizen rather than being given some sort of temporary status for many, many years with never an opportunity to become a green card holder and then a citizen. So there is this road. There's also in creating that road, they created 4 new immigration statuses that are mentioned in the bill. The first one is the registered provisional immigrant status, and that is a status most people will be talking about from now on. It is the road for most of the undocumented immigrants as of right now that they would take. So the first step that they would take to become lawfully here is to apply for that status. There's also a provision for agricultural workers, and they are given a different path, and it's known as the blue card, and I'm going to go over a few of these details in a minute. There's also a new family visa, which allows people whose family members are waiting in other countries and have already applied for a green card but are waiting years and years, that they are allowed to actually come to the United States on a V visa and wait for their application to be processed here, and it's a really good thing in terms of family reunification. And then we have another visa, the W non-immigrant visa, which is focusing on low-wage workers. There's been a lot of discussion about high-tech workers, and so I think and agricultural workers, of course, and so this W visa is trying to address sort of the non-skilled workers, but I will defer to Angelica on more information about that. There's also a mandatory E-Verify provision. Before, E-Verify was sort of seen as if you couldn't get E-Verify, we didn't want E-Verify unless there was an actual path to citizenship, and so because there is this legalization path, there's an assumption that now everybody every employer will have to have this E-Verify system to check work authorization, and it will be mandatory right now for all employers. There are no exceptions right now. And then finally, I'll just skip to the end. There's different improvements in the immigration reform process. They're trying to address this long backlog. They're increasing the number of visas, but they did eliminate the ability to sponsor your siblings, and there is also elimination of what's known as a diversity visa program. And then there's a whole discussion about how we're going to let people apply for legal status in the future, and whether it's a point system and how you're going to be evaluated to be considered an eligible immigrant. Next slide. So this is a quick graphic on sort of what the specific provisions are for the road to citizenship. There's obviously more detail than I'm putting here on the slide, but just want to give you some broad strokes. So this is the main road that, again, most undocumented immigrants will have the opportunity to take. After the bill is passed, about 2 years, let's say, after the bill is passed, they will have an opportunity to apply for RPI status, and you have to pay a fine of $500 plus the application fees, which we don't know yet. You're then in that status for 6 years, and you have to get that status renewed at year 6. And again, there's fines and fees, and there's some other requirements. And then after 4 more years in that status, you can finally apply for a green card after 10 years. So you're in RPI status officially for 10 years. It'll probably be a little bit more than that, but let's say a minimum of 10 years. And again, pay for fines and fees. And then you can adjust for citizenship after 3 years in a green card status. Again, paying fines and fees. So at the box at the top, it says for a total of 13 years, to get your citizenship from the date of application plus all the fees and fines. Next slide. So there's been a lot of attention, of course, for the Dreamers, the kids, the undocumented kids, and I know there's great support for it. So what they've decided to do in the Senate bill, at least, is to shorten their path to citizenship. So like all the other undocumented immigrants, they still have to apply first for RPI status. There's not a special dream status that they're going to apply for, so it's RPI. But at the end of 5 years, instead of waiting for 10 years, at the end of 5 years, they can get their green card and also their citizenship if they choose to apply right away. They can remain in green card status, but they can apply for citizenship without waiting another 3 to 5 years. Next slide. So on the blue card visas, as I mentioned, it's to be eligible, you have to have shown that you've been working here as an agricultural worker for so many hours and days, and then you're in that blue card status for 5 years. Again, you're going to have to pay fees to apply for this. Once you complete 5 years, you can apply for your green card, and just like it is under current law today, you have to wait another 5 years to be able to apply for citizenship. Next slide. So where does this leave us in terms of access to health care? So this is a slide just to remind folks what the status quo is right now before immigration reform. So under the Affordable Care Act, the way immigrants are basically covered is if you're lawfully present under the ACA's definition, and those who are undocumented. And so if you're lawfully present, you are eligible for mainly the exchange and the tax credits, which APTC is the Advanced Premium Tax Credit, sorry for the acronyms, and CSR is cost sharing reduction. So you're, if you're lawfully present, you're eligible for that. Actually, I wrote this wrong. So there is no 5-year waiting period in the exchange. It should say excludes 5-year bar. There is no 5-year waiting period. So the minute someone, for example, gets their green card today, they can immediately apply for premium tax credits and cost-sharing reductions. So there's the 5-year bar still applies, however, to Medicaid and CHIP, as you see above, and there's still a narrower definition of who's who's eligible for Medicaid. So there are going to be in California many lawfully present immigrants who are not still eligible for federal Medicaid and are still subject to a 5-year bar. And so they're technically eligible for the exchange, but many of them we currently cover under our Medi-Cal program, our state Medi-Cal program, and I know Ron's going to talk about that a little bit later. So because everybody has access to these coverage options, they're all subject to the individual mandate and can get exemptions just like everybody else. So that leaves out the undocumented. Basically, they have no access to the exchange, no access to the subsidies, and they're left with emergency Medicaid or restricted Medi-Cal here in California. They are exempt from the mandate, and they remain eligible for all the community health centers and public health options. Next slide. So after immigration reform, let's say the Senate bill actually becomes law the way it is written in right now. The statuses on the right-hand side are the main statuses I went over. So RPIs, Blue Card, and V visas, the way the bill is written right now, while you're in any of those statuses before you become an LPR, you are basically excluded from everything. So you're excluded from Medicaid and CHIP, for sure. You're excluded from the ACA tax credits, both the premium tax credit and the cost sharing reductions. You are exempt from the individual mandate. At least that's the goal right now. And so basically you don't have access to any affordable care. You can buy insurance in the exchange now at full price. That's because technically now they're lawfully here, and so they're not considered undocumented, but they are not lawfully present in terms of ACA's definition of for the exchange and for tax credit purposes. So it's almost like they never changed any access, basically, even though they have lawful status. They're still eligible for emergency Medicaid, and they're eligible for community health centers. The only slight difference is they could buy full price insurance in the exchange, which we probably think is not going to be affordable to them, and so they remain pretty much uninsured. Next slide. So just wanted to flag, I won't spend time here, but there's a lot of still more potential. It could get worse. So if we think it's already bad enough that everybody's been excluded from everything, it still could get worse. They could add further waiting periods. They could add further restrictions to make it harder for people to remain on the path if they, for example, use health care in any way. So we are monitoring that very closely and making sure that those kind of restrictions don't get added, and that we educate folks that there are already enough exclusions and restrictions on folks that are on the road to citizenship, and that's already wrong. Next slide. So I'll just briefly mention, just to tee up for the other presenters, that there's a lot of work that can be done for if you're interested in actively, following the immigration reform debate. there's a campaign called the Healthy New Americans campaign, and we focus specifically on access to health care in the immigration reform debate. And there's a larger campaign that Angelica can talk about is for just general immigration reform updates and engagement. We are still trying to push for bringing back the Access to Affordable Care Act, like removing the restrictions that are already there. It's going to be a heavy lift, but we are still pushing for that fair access. And basically, we want to make sure there's no further harm to immigrants, and whatever access they still have today, that they can at least maintain that. All right, I will stop here.
So then I will proceed, and just following up, first I want to really thank Sonal for just a really condensed a lot of technical information very succinctly in this. So what I want to follow up is with her presentation is first to say that Healthy New New Americans campaign is also part of many of the organizations working on that campaign are part of the Alliance for Citizenship and other campaigns at a national level fighting for just and humane immigration reform. And when we mean just and humane immigration reform, we're talking about really allowing immigrants to be full Americans in every single way, politically, as well as access to the basic safety net and certainly access to health care. However, there's maybe a step a little bit back before I enter there. There's a lot we can do from California in order to influence the healthcare debate in immigration reform. And I really feel that it is important that we begin now, immediately, in order to have our voice heard from California on healthcare. Next slide. And so, as was described earlier by Sonal, what's happening right now in immigration reform is we just passed the Judiciary Committee, a major step forward for immigration reform, in which the group of 8 that put together the bill held really tight in not allowing additional amendments on certain things that we wanted to fix on the issues of health care. Many senators did not take up this debate, or it took up the amendments to improve it. We improved it in other means, but certainly not on the health care component. And so now we have another chance, and that is on the floor of the Senate, in which Senator Feinstein and Senator Boxer, pictured here, are incredibly important in order to ensure that, one, as Sonal described earlier, this bill doesn't get worse in terms of access to health care, and that amendments that will be submitted by other senators who are not part of the Judiciary Committee, that are not part of the group of 8, will now be moving forward. So immediately we need to engage Senator Feinstein, and now Senator Boxer becomes an important ally. Senator Boxer has always been a strong champion for access to health care and access for working people of all, on all issues, and is one of our, I would say, fiercest champion. So she becomes very important to safeguard immigration reform, to continue to make it progressive, but also to safeguard issues around health care access. Next slide. So now I want to talk a little bit more about the politics and what's happening in the House of Representatives, and why this conversation is actually so timely, this webinar is so timely. So as the negotiations move forward in the House of Representatives, there is a push by certain members, mostly of the Republican Party, and Sonal kept saying they. Well, they are members of the Republican Party who do not agree on having immigrants who will now be on this RPI status have access to any benefits, and who also believe that individuals on this path should not be public charges, and has to demonstrate that they will never cost the government any money. And so there is a whole focus on really making it very difficult for the undocumented to really have access in the way that everybody else. And one significant point of debate, and also was alluded by Sona, was that there are some members in the House of Representatives that want to push to make contingent on staying on this RPI status, as was described by Sona, where you were on this path for 13 years, that you must be required to have health insurance during the entire 13 years. But as described earlier, many of immigrants will not be exempt, are exempt right now from the individual mandate, but this requirement would not make them exempt. In fact, they would be mandated to have health care insurance. The assumption is that they will have health care insurance through their employers, but as we know very well, that's not necessarily the case. And they would be required to buy the product in the private market at the full price. And as we know very well, there's also the issue of low income individuals who are low income, who many of them are working 1, 2 jobs and still living below the poverty level. And as described earlier, there's no access to the ACA subsidies for low-income individuals. And there is a worse situation in the House of Representatives, that certain Tea Party representatives want to use the immigration reform debate to reopen the debate on the Affordable Care Act in the same negative manner in which it was had when it was moving forward. And as you remember, this is the moment where the president's speaking to Congress, and he was challenged as to whether or not the undocumented were going to have access to health care, and that just kind of spiraled out of control in fully excluding undocumented immigrants from the Affordable Care Act, as was earlier described. So one of our fears is that the real goal is to attack the Affordable Care Act, and also by so doing, put more negativity towards the Affordable Care Act, but also stopping the momentum of comprehensive immigration reform. Next slide. So what can we do right now? We can educate our California elected officials that are critical to this debate. So in the House of Representatives, there is also the Gang of Eight, the Group of Eight, that is negotiating a House version. It's possible that this version that has just been approved in the Judiciary Committee can also be adopted by the House of Representatives, but it is also very probable that we will have the House will have its own bill. So negotiating on our behalf in the House Gang of Eight, we have Zoe Logfriend from San Jose and Javier Becerra. So these are very important individuals to engage with in a conversation on immigration, on immigration and healthcare issues. Additionally, we have Nancy Pelosi and Kevin McCarthy, who are leaders in both of the in the Democratic as well as the Republican Party, who are leaders who are going to have complete oversight as to what the bill that moves forward looks like. So we're, in a sense, we're in California, we have the ability to influence these two very important individuals. And I would say Kevin McCarthy is important to move immigration reform in general, but Kevin McCarthy is also really important in order to make sure that the situation around healthcare is really reined in, and most importantly, that we don't have those who hate the Affordable Care Act use immigration reform to further to do further damage to our community. Next. So what needs to happen? We also need to engage healthcare experts and advocates in the comprehensive immigration reform debate. As was stated earlier, the Healthy New Americans campaign is underway, but many of these decisions are being made without the expertise of healthcare experts, doctors, etc., individuals who really understand the situation of Californians, which we will learn more about. So we need to engage your voices in this debate in a very significant way, and to educate the aforementioned leaders around some of these components in terms of what does it really cost an undocumented immigrant who will then become who will then enter into registered provisional status. How much is it going to cost that family, that individual and that family, to pay for health care insurance, and what is that impact on their wages, but also how realistically is this going to be? And it could mean that this is a way by which to just make the path to citizenship certainly not a reality, a mirage, but also by which to, certainly make it impossible for people to meet those requirements. So we need you to monitor the debate. We need you to write op-eds about the importance of protecting everybody's health care, as you have done many times, and also to participate in comprehensive immigration reform activities and delegations in California and in D.C. to lift your voices on behalf of immigrants and their need for access to health care. Next. So there are certain opportunities that are currently underway. We will have our members of Congress back in town May 27th through June 2nd. A very important opportunity for individuals to weigh in. We will also be having actions on throughout the month of June, and really just want to say to you that we invite you to stay connected to the campaign, the Healthy New Americans campaign that was mentioned by Sonal, and also connected to activities that are happening on immigration reform through the California table. And so for more information, you have my contact info, and I think we're now open for questions.
Great. So this is Josue Chavarin from the California Endowment. We actually didn't receive too many questions from the Q&A chat box. Again, if folks have questions, please direct them to me through the Q&A chat box. I think we will go ahead and proceed to the next section, and we'll have a bigger Q&A once the presentation is over. Thanks.
Hi, this is Ronald Coleman from the California Immigrant Policy Center. I'm going to talk a little bit about ensuring access to care for all Californians. Next slide, please. So the California Immigrant Policy Center was founded in 1996. We're a nonpartisan, nonprofit statewide organization that seeks to inform public debate and policy decisions on issues affecting the state's immigrants and their families. CIPC engages in legislative advocacy and also provides technical assistance, training, and education on immigrant issues. Next slide, please. So here's just a roadmap of a little bit I'm going to present on today. So I'm going to offer some facts on coverage related to immigrants in California currently, and then also talk about coverage available for immigrants under the ACA. However, I'm not going to go into too much detail about that since Sonal covered that in her section. And then also talk about some of the Brown administration proposals that are related to immigrant health. Next slide, please. Next slide, please. All right, so California's uninsured, ages 19 to 64, in 2009 was mostly citizens. As you can see from this chart, about 57% of those uninsured in California were citizens. Non-citizens made up 43%. Next slide, please. However, as you can see by this slide, California's immigrants are disproportionately uninsured. So this chart shows 2009 data for coverage by citizenship for those ages 0 through 64. So as you can see, starting with citizens, it's about 17% of the individuals are uninsured. And then when you go to non-citizens with green card holders, essentially legal permanent residents, their rate of uninsurance is 37%. However, when you go to non-citizens without green cards, you see that the rate climbs much sharper to 55%. So as you can see, there is much need of more health coverage depending on your immigration status. Next slide, please. So immigrants are working, and as you know, oftentimes people get employment-based coverage. Unfortunately, though, working immigrants actually get less job-based health insurance or employment-based coverage in the market than other workers. And as you can see by this chart, this shows, some of the sectors that immigrant workers work in. And immigrants actually represent 15.8% of the civilian employed population overall, but are overrepresented in high and low skill industries. So as you can see right here, if you look at those who work in private households or accommodations or warehousing, it is significantly immigrant populations, and these are definitely job sectors where it's less likely to have employment-based coverage. Next slide, please. So Sonal did a great presentation on this a few minutes ago, but there are coverage options available to immigrants and their families, of course, in the California Health Benefit Exchange, through the expansions of Medi-Cal and through other safety net programs. For the most part, as Sonal mentioned, lawful presence is the definition in the ACA. So if you're considered to be lawfully present, you would be eligible for the California Health Benefit Exchange or Medi-Cal, unless we'll talk about some of the issues addressing some of the qualified immigrants that are subject to the 5-year bar. But for the most part, if you're lawfully present, you would be able to have benefits from Medi-Cal as well. And also, there's many safety net programs available as well for the undocumented, whether it's public health programs that may be available regardless of status, if it's dealing with immunizations or some type of communicable disease, or it could be another type of state-only program that deals with a very specific illness, or, of course, we have the county 17,000 obligation, which is a requirement for the counties to provide care to those that are indigent and uninsured as well. Next slide, please. So who's eligible, who's not? I'm not going to go through this in too much detail. Naturalized citizens, just like U.S. citizens, are able to benefit from the ACA lawfully present. There is no 5-year bar in the exchange, as Sonal mentioned. They are entitled to tax credits and subsidies, and may have the benefit of the Medi-Cal expansion as well. For undocumented immigrants, they're not eligible for the exchange even at full cost, but they are eligible for emergency Medi-Cal and the public health programs I mentioned earlier. Next slide, please. So there is a proposal related to immigrant health that the governor is currently pushing right now. And next slide, please. And it's related to the state-funded Medi-Cal program. So both before and after the 1996 welfare law that passed in Congress that changed immigrant eligibility for lawfully present immigrants that were 5-year barred in federally means-tested programs, California continued to provide access to this population as solely a state-funded function. So it's solely funded by general fund dollars. There is no federal match, and we do have qualified immigrants subject to the 5-year bar in this program. It's about 76,260, and there's also about 26,000 permanently residing under color of law, which are PRU-CALs. And, PRU-CAL is not an immigration status. It's just a benefit eligibility category that simply means that the Department of Homeland Security knows that the individual is here, but doesn't have the intent to remove or deport. So, we definitely appreciate this benefit eligibility category here in California, especially in Medi-Cal, which provides full scope benefits to that population. So, Governor Brown proposes to have all recent lawfully present immigrants apply for coverage in the exchange. This was both in his January proposal and his May revised proposal. In January, we were a little concerned because this would have been the only population that would have gone to the exchange that would have been under 138% of the federal poverty level, which would have been very difficult for that population. You can imagine if somebody's making $600 a month, they're definitely going to have a lot of problems paying for cost sharing and premiums. So we're very concerned about what that may mean moving forward. However, in the May revised proposal, we did see that Governor Brown did acknowledge that there were certainly affordability concerns and benefit concerns. So he developed a mechanism for an affordability wrap and a benefits wrap moving forward for this population. However, CIPC supports putting all recent qualified immigrants subject to the 5-year bar into Medi-Cal, both those that are currently eligible for the program and also for those childless adults who would be newly eligible.
But under the proposals that are moving forward right now, both ABX11 and SBX11, we're very pleased that those bills, being silent on the state-funded program, certainly maintain and preserve the program, but unfortunately don't expand to the childless adults. However, we're definitely working with leadership closely, who, wishes they could, do some changes that could put this population in. However, there certainly are concerns about where the governor is, or how the governor is framing this conversation around the fiscal note and the potential threat of a veto moving forward. Next slide, please. So just quickly, I just wanted to go through a few concerns about this transition for this immigrant population. So, the affordability wrap and benefits wrap, I think we're very concerned about how they may work operationally in the exchange. We definitely want to make sure that a person's plan is getting paid for, and that at the time that they see their provider, they're actually able to access their health coverage and actually get met for whatever needs they're coming into the doctor for. As it relates to benefits, there's minimum essential benefits in the exchange. However, the childless adults are supposed to get benchmark benefits. We definitely want to make sure that this population, who could potentially be pushed to apply into the exchange, definitely has access to both of those types of benefits. And also in Medi-Cal, there's due process because it's a government benefit, and I think we want to make sure that we have these protections for this particular population as well. And I think for this issue, AB 617, there certainly is an issue related to there certainly is a bill moving forward by Assemblyman Nazarian that would address some of the due process requirements in the exchange. And I shouldn't really call them that. It's more the exchange appeals process, but it is supposed to mirror the due process of Medi-Cal for this particular population. Second thing is we want to make sure we keep families together. There's likely to be children in Medi-Cal under the CHIPRA option, and we certainly want people to be in the same network, be able to see the same provider, and also have the same benefits within the same family. Next slide, please. So there are definitely next steps, working with the Brown administration on next steps to address some of those concerns that I just mentioned for recent lawfully present immigrants. However, we certainly need to be mindful of what could occur with some of the other state-only programs like the Breast and Cervical Cancer Treatment Program, ADAP, the Genetically Handicapped Program, AIM, Access for Infants and Mothers, Family Pact. I think, in the future, we definitely need to keep our eye on these programs to make sure that, those programs that are available irrespective of status continue to be available to Californians, especially in light of what we see with immigration reform moving forward, and there being such long delays and restrictions for people that are going to be getting some type of legal status. So the last thing I'd like to say is on the remaining uninsured piece is, as we really move this historic expansion of new coverage forward under the Affordable Care Act, we will significantly cut the number of uninsured Californians in half at least, and we may even actually reduce the number of uninsured people in California by 2/3. Still, it is estimated that 3 to 4 million Californians will remain uninsured, and approximately 1/3 of the remaining uninsured will be these new American immigrants who may soon be on a roadmap to citizenship under federal immigration reform. California certainly has a stake in the health and success of all its residents, and these new Americans, they're going to be continuing to work, they're going to continue to pay taxes, and be continuing to fully contribute to our economy in California. So it's really important for us to ensure that this population is healthy. Even with implementation of the Affordable Care Act, cost containment, elimination of health disparities in communities of color, and a truly healthy California will only be a dream if our state's policymakers don't take actions now to ensure that everyone has access to health care regardless of immigration status. And maintaining the health safety net at the county level is an investment in the future for all Californians. Next slide, please. So that's my contact information if you need to get in contact with us. I'm now going to turn it over to Anthony, who's going to dig into the remaining uninsured proposal into much more detail. Thank you.
To be here and be part of this presentation. Again, Health Access is really pleased to have been working with our partners on the issue of how do we make sure that we provide care for all Californians, including immigrants and community color communities, but everybody, and really fulfill the promise of the Affordable Care Act. This is based on a concept paper that we released with some of our partners here today. A couple of weeks ago. It's on our website at www.health-access.org. On the front page is the joint statement by several organizations that has a one-page summary of the proposal that folks can use for their advocacy. There's also a 12-page concept paper that goes into more detail about this proposal. Next slide. You can also follow us on Twitter at @HealthAccess. And I'm sure the California Endowment would love if you use the hashtag #HealthForAll. So we're now in a moment of, we're in the next 2 weeks, we will decide how we implement the Affordable Care Act. We will make a decision about how we implement the expansion of Medi-Cal and do the other final things we need to do so that California can be ready to maximize the benefit in 225 days when the expansion will happen on January 1, 2014, and frankly, in less than 5 months, in October October of this year, when open enrollment starts. It's a big deal. There are some still differences between where the governor and the legislature is about making sure that people can most easily get on Medi-Cal and stay on Medi-Cal as part of the expansion. But the biggest difference is that the governor has said he really wants to tie the Medi-Cal expansion to taking some dollars from the pool of money that goes to fund the county safety net, the funds that go to fund public hospitals, clinics, county low-income health programs, safety net providers, public health services, and that is fundamentally the debate, and that's what we need your engagement on in the next week or two. We need your engagement on this fundamental fight because we need to preserve the dollars for the remaining uninsured because we will have significant numbers of remaining uninsured. Next slide. This is a slide from the University of California that talks about that shows the undocumented are a portion of the remaining uninsured. If we do a great job with enrollment, we'll have 3 million remaining uninsured. If we don't do as good a job, we might have 4 million. But the point is that this is that there will be undocumented, but there will be other categories as well. Next slide. That includes people who will be frozen between open enrollment periods in the exchange-covered California. That includes other populations. So we need to have a strong safety net for it. I mean, don't get me wrong. There will be millions of people who will be covered under the Affordable Care Act, including communities of color, including immigrants. But we also need to make sure that there's an option for those who are left uninsured for all Californians. Next slide. We think California must lead on both sides, on both implementing the Affordable Care Act for the newly insured, but also making sure that there is safety net care and coverage for the remaining uninsured. Next slide. So here's what the debate is about. There is about $1.4 billion of money that goes from the state to the counties earmarked for county health care. That's what's in debate right now. Counties have an obligation to provide some care to the quote-unquote medically indigent. It's called the 17,000 obligation. But counties vary wildly on what they provide. Some run whole public hospital systems. Others have some clinics. Others pay private providers to do some care in more limited or expansive ways. Some serve the undocumented. Others do not. Next slide. So we need to make sure that we need to preserve what we have and actually see if we can improve it because it is so invariable and it does create issues that there are counties that are so very wildly different. The governor's proposal explicitly says he wants a formula that takes savings from the county to recognize the fact that we are now covering some of the currently uninsured, that we're covering some of those folks. His philosophy is we need to take money to recognize that. He has some estimates in his May revise of the budget. He wants to take $300 million in the first year, $900 million in the second year, and $1.3 billion in the third year. That's more than 75% of the dollars that go to public, that of the state dollars that go to public hospitals, to community clinics, to safety net. That's what the governor wants to do in his proposal. Obviously, we think this is too much too soon. This means that we need to have counties should not take money for the first few years. That the state shouldn't take money for the first few years. The counties say that at the time of peak demand, when most people will be coming into the system, you don't want to be taking money out at exactly the moment where there might be more need. The governor wants to tie this to a very complicated programmatic realignment of human services, which we don't think is viable or necessary at this moment. What it does do is it basically says that the counties get reimbursed for the cost they have now, but nothing more than the cost they have now. So it basically would lock in counties to the decisions they have made in previous years, and actually would base it on the last 4 years, which was the greatest recession since the Great Depression. And it was a time when counties actually scaled back their health care services, when they closed clinics, when a number of counties said, you know what, we're no longer able to cover the undocumented, like Contra Costa and Yolo and Sacramento County did. And what this would do is it would lock those counties and all counties into what they're doing today. Even it would take savings for the fact that there's some part of their population that would not be covered, but it doesn't allow those counties to then redirect their efforts to other populations that are equally in need of coverage. So it's a formula based on historical costs, not future needs. It doesn't take into account health reform, changing demographics, different health markets, etc. So next slide. So we have a different approach that is a vision of how we can actually do this successfully, which is we have the counties run. Right now, as a bridge to health reform, counties run these low-income health programs. We've learned to do the safety net in a better way, not just to provide emergency care or not just to provide emergency or episodic care, but to provide primary and preventative care, to provide a real medical home for people so that it actually is a more efficient and effective way to get people care. We've been doing that with 53 counties out of our 58 counties have been doing that and serving 600,000 people as a bridge for those folks who will then be switched into full Medi-Cal on January 1, 2014. So without legislative action, these low-income health programs, otherwise known as LIPs, would expire, go away at the end of this year. And our proposal is, let's keep these LIPs up and running and targeted toward the remaining uninsured. We need to build on this infrastructure. We shouldn't let this infrastructure go away. We should build on this infrastructure to meet this ongoing need that we have. And our proposal is then to tie the dollars that is in dispute to whether counties actually set up a LIP and based on their enrollment. So if they can show that there's an ongoing demand, and if they show that they can meet that demand, then they should be able to keep the money. So next slide. So our vision here is that we want to be the county's best ally in protecting the funds that go to the remaining uninsured. But we also want to say it needs to be tied to actually providing a service to the remaining uninsured, including the undocumented. And so this slide goes into some of the more details about how we would structure it. I recommend you go to the website to look at our concept paper, etc. But I do want to get to the action items. So next slide of the work that we have yet to do. So we have great support from a number of organizations, including some on the call today. We got support from the editorial boards of the Sacramento Bee and the Los Angeles Times. Next slide. And a brief just came out yesterday that talked about how providing this kind of medical home model actually would really improve health outcomes. Next slide. And so we just fundamentally believe that this is a resolution to this issue of California is stronger when everybody has access to health care, and let's not lose this basic infrastructure. Next slide. We want to make sure that immigrants are included in safety net care and coverage, and this gives the counties the incentive to continue to provide that coverage. Next slide. So let me go to the next slide because that's the action piece, which is what we need your help on. We need your help. We don't have months on this proposal. We have days, if not weeks, if not days. The budget will be decided in the next couple of days in June 15th, and so this issue will be decided literally in the next week, if not two. We need. There's negotiations with state and counties, but ultimately this is up to the governor and the legislature and the key legislative leaders. Next slide. And so we need your help to communicate with legislators. There will be call-in days starting this Friday to call legislators to get and two big messages. One, protect the county safety net, the dollars for the county safety net, and two, cover the remaining, provide care and coverage to the remaining uninsured, extend the low-income health programs. And that would refer people to this proposal. We're trying to do delegation visits with key legislators because we want the legislators to impress upon their leaders that the remaining uninsured is a priority. Amongst many priorities in the budget, this has to be a priority. We ask people to do events around California to spotlight the issue, to invite legislators. We also need stories of people who would be impacted, of who benefit from these low-income health programs now and who would in the future if we were able to maintain them, people who would not be qualified for the affordable care, the Medi-Cal or Covered California, but still need a place to go and to provide at least some basic necessary piece of care. Final slide. So, again, here's our information. We very much appreciate your advocacy and activism and engagement, but this is sort of something that's very exciting. We have the opportunity to fulfill the promise of the Affordable Care Act for all Californians, but we need your help to do it in the next couple of, in the next days and weeks to get this done. Thank you very much. And so with that, Josue, I know I'll pass it on to Chad Silva from the Latino Coalition for a Healthy California.
That's correct, Anthony, and just one more slide that I kind of inserted. If any of you have any questions or want some updates, please email me at jchawarine@calendow.org. And I've received several questions relating to whether or not this presentation will be provided for folks, and it will. I will send out an email with a recording of the presentation as well as PDFs of the PowerPoints. With that, we'll move on to Chad.
Good afternoon, everyone. This is Chad Silva, Policy Director for Latino Coalition for Healthy California, and I'm going to be focusing particularly on the Latino community because it represents the largest minority population in California, approximately 47–48% of the population of California. We're also a broad, sweeping population. Not only do we represent, middle-class folks, but we also represent low-income and undocumented populations. So the safety net, in many ways, is very, very important to us, as it is to other communities of color. And I think that I will couch these comments also with the proviso that I am also speaking of some of the issues that are going to be affecting other communities of color, such as African American, Asian Pacific Islanders, Native Americans. Next slide. And these are Latino specific. Again, of the 38 million foreign-born people in the U.S., California is the greatest number. So again, California is a state of immigrants, a nation state of immigrants. Again, it's estimated that nationally a majority of the undocs are of Latino ancestry. Nearly half the children in the state have at least one immigrant parent. So again, that raises an issue of mixed status. Again, we might have varying degrees of citizenship. Some may be covered, some may not be covered. So and that raises the question, well, do we really want folks not to be covered? We want to make sure that everybody has access, and it doesn't seem fair, especially when you raise the mixed status issue, that folks would have access and others not. Next slide. again, this again points to the fact that California, probably above most others, is an immigrant state. It is a destination, not just for folks from in our own country, from across the nation, from other states, but also from other countries. And it is quite a sizable chunk of folks that live here who are from abroad. Again, 37% immigrant, and 26 total population, 37%. This is old. So we are saying that, you know, most, a good chunk of those Latino immigrants are actually, oh, did I say 48% earlier? I meant 38, almost 40% Latino. So again, we have the 26% immigrant of that population. We can move to the next slide. And again, we want to make sure that we're also pointing to the fact that a lot of the Latino population, it doesn't say it in the slide, over half of those between 0 and 17 today are Latino. In 2009, 2010, over half the children born in California were to Latinas. So we have a very young population. I think the median age of Latinos in California is 27 compared, I think, to 48 for all of the population. Compared to the white counterparts. Again, and then we have to look at, well, access. Again, it's estimated that 170,000 children will be barred from enrolling in Medi-Cal, purchasing private insurance in California and the exchange, again, due to they or their parents' immigration status. Next slide. And here are some of the, you know, of course, some of the bars. California, 5.7 million Latinos will be newly eligible for purchase insurance in the exchange. Again, the prohibition against undocumented immigrants. An estimated 6.4 million Latinos in California will be newly eligible for coverage under Medi-Cal. Again, immigrants are unqualified for coverage due to their immigration status. And as we saw, Sonal, that's going to remain the case no matter what happens with those other statuses. Next slide. Again, we have these numbers, 30,000 undocumented immigrant children will be barred from participating in covered California. Approximately 150,000 uninsured children will be excluded from ACA-funded Medi-Cal expansion due to their status or their parents' immigration status. And, you know, these slides will be available, so I'm not going to spend so much time on them because I want to be able to have question and answers for the folks out there, so we can move to the next slide. And here's a good graphic that shows, you know, health insurance coverage of family citizen status, and I think that Ron provided a similar one, and really shows, you know, what the percentage of coverages is for depending on immigration status. So this can be useful. Next slide. So this is another, again, I think Sonal really touched on this very, very well. This really just breaks it down. About undocumented immigrants. There's no federal coverage. 1996 made sure that as a matter of law, because we were placing restrictions on those who were lawfully present. So, of course, undocs are, you know, by law just excluded. Not allowed to purchase insurance exchanges. Not eligible for premium tax credits. Exempt for individual mandate, not eligible for Medicare, non-emergency. So basically all of and food stamps is included there, what we call federal means tested benefit. But they will, of course, remain eligible for emergency care. That is emergency room visits. Next slide. So this is we get to the point here. California's community clinics and public hospitals will continue to serve a significant number of uninsured. And a lot of those, as we've seen, are going to be Latino. Not only will they be Latino, but they'll also be Asian Pacific Islander. They'll also be, you know, other statuses and other ethnic groups, particularly immigrant groups, that are going to have some trouble gaining access. Next slide. And this is currently within, you know, the government's may revise, which is exactly what Anthony was referring to. Again, the proposal to pull, you know, $300 to $1.5 billion from county safety net funding. And another piece of that is moving all currently eligible but not enrolled legal permanent residents, along with those who would be eligible under expansion, to childless adults in the covered California. So no state-only Medi-Cal expansion, as was said earlier. And we have some issues with this. And I think this was also covered by SIPC, by Ronald. Covered California, one of the big ones is that Covered California does not have as robust language access requirements as Medi-Cal. CPCA has done a really good side-by-side comparison of the various language access provisions. And in discussions coming from and talking with them, it's by no accident that they are not as robust under Covered California. And so, as we've seen, with this being an immigrant-centric state, and with a lot of folks fitting into one or more family members fitting one or more of those immigration statuses, and LEP population also being significant in California, language access is very, very important, particularly for this group that's going to be moving into the exchange. And again, we want to make sure, again, since we're now moving folks out of Medi-Cal, and that this also, and that we won't be augmenting the Medi-Cal, and that eventually folks will start moving out of Medi-Cal as they start hitting the 5-year bar, that the level of funding for clinics can be affected due to the rates they received for covering and providing care to Medi-Cal folks. So we're getting hit not only on clinics in particular are not only going to get hit on this county money that might get pulled out for those who have contract and provide care at the county level and with the counties and for the counties, but also those who provide Medi-Cal coverage. And so I think I'm not going to belabor what you can do. I think that was covered quite well by Anthony and by Ron. I think it's important to get engaged. I think it's important to make sure that you let your local reps, your local senators know that it's very important to maintain funding for clinics, for the safety net in general, because it's not just the immigrant population, it's a low-income population as well, and it's those who will be churning in and out of coverage for various reasons. So we're not just talking about services for those who aren't currently covered under the ACA. We're talking about those who could be currently eligible, don't get signed up for whatever reason, and happen to slip through the crack. And we're also talking about folks who are currently in good economic shape, but for one reason or another may slip and may not, may be in a position where they can no longer afford the insurance they have, and are in between coverage, and so need that safety net to fall back on. And that's why it is a safety net, because ultimately I think we need to remember that the safety net is for everyone. It's not just for those folks that I've been talking about, but it's for you, it's for me, that but for the grace of God, we may not have to go, but may end up having to use at some point in our lives. So I think that I just want to emphasize that we need to make sure we're engaging the governor's office. We need to make sure that we're writing letters. We need to make sure that we are writing op-eds. We need to make sure that we're getting in touch of our elected officials and letting them know that the safety net isn't just about immigrants. It's very important to our population, but it's important for everyone because everyone may find themselves needing those services. Thank you. Last slide is my contact information, and that concludes my presentation.
Wonderful. Thank you for that. I'm going to go ahead and unmute all of the panelists now, and Sonal sent me a message. She actually received some questions herself. I think I want to open this up as an opportunity for her to go ahead and address those questions that were asked to her.
Great. And I am going to call on some of my fellow presenters to help with some of these questions. But I'm going to try to address the ones that you sent in that were specific to the immigrant eligibility pieces. So maybe it's best to just repeat the question. So there was a question about what LPR stands for, and it's lawful permanent resident. and I have more details in the Q&A box if you want to look. And then I was going to skip to the question came in about from Jessica that the question is, we've heard of undocumented residents who have TINs and have been told by their tax preparers that they'll be subject to the penalty if uninsured after 2014. Is this accurate? So I want to thank Jessica for this question. I think there's a lot of confusion, and I think one of the other really big action items that all of us can participate in right now is community education and really explaining to immigrants what the rules are under the ACA, because they are going to hear a lot of misinformation. So under the federal rules right now, the regulations that just came out, everybody is subject to the individual mandate, including dependents. And so but you are only penalized if you are actually a tax filer and a taxpayer. However, if you are still subject to the mandate, you can request one of the exemptions based on affordability. And as I mentioned, not being unlawfully here, undocumented, is an exemption that you can let the IRS know is the reason why you don't have health insurance. So I think that, as Chad raised, the complication, especially for California, is a mixed status family, where the parents may be exempt from the mandate, but if dependents are subject to the mandate and parents have to get insurance, then potentially they could be penalized if the child isn't insured. So this is also another critical reason why we need to get all mixed status families enrolled in the programs that they're eligible for. But so I guess I'm saying they're subject to the penalty, but they can get an exemption, especially if it's unaffordable to them. They can also get an exemption for that. Does anyone else want to comment on that question?
Yeah, and I
think you did it well.
Angelica, were you going to say something?
Yeah, no, I was just going to say, in terms of having an ITIN too, I mean, that's clearly you do not have a Social Security number by which to file your taxes, so automatically that would disqualify, that person would be exempt. But obviously, I think this question brings up the education of tax preparers and others who are engaging with our community, and so we have to do the kind of education for folks to be able to fend off some of those misconceptions. And so I just think that certainly it really, I would say, prompts us to be prepared prior to April 15th, when everybody's filing taxes, to make sure that they have the correct information. So thank you for that question.
So I'll take one more, and then I'll turn it over to one of the other panelists for some of the other questions. So the next question I'd like to address is a question from Jacqueline. What benefits will naturalization of our undocumented immigrants bring as far as access to health care for everyone is concerned? So you're right that everyone's affected by the fact that immigrants are excluded. So I think your question is basically asking, when someone gets their citizenship, what benefits to health care they'll have. As I think I went over my presentation, even under immigration reform, while they're on that path to citizenship, they're unfortunately being excluded when we thought that just, we were going to fix it during immigration reform, the fact that they got excluded. But now they're having to wait at least 13 years before they can actually get access. And once you're a naturalized citizen, you have all the same benefits and privileges to benefits that U.S.-born citizens do. So that is also one of the goals, is to make sure immigrants have that pathway so they can fully participate. But in the meantime, we also want them to fully participate and have access. So let me turn it over to maybe Anthony. Do you want to try to?
Yeah, I think, obviously our preference in any situation is for people to get covered, for people to get, for people to have private coverage in the exchange, subsidized, so they don't have to pay more than a certain percentage of their income, or to get Medi-Cal coverage, and again, and obviously getting folks on the path to citizenship, naturalization, citizenship helps in that regard. And as Ronald pointed out, there is actually a pretty good correlation between your immigration status and being covered, and so there's that by itself is a big way of getting people access to health care, is if they are in more legal, more naturalized, more citizenship statuses, because that not only gives them more access to public programs, but it also means that they're more likely to have the market power in the job market to get private coverage, employer-based coverage. That being said, we want to make sure that there is something. We always want to make sure that there is a safety net for those who are not covered, and that's what the proposal that I outlined talked about, is that if you do not qualify for the exchange, if you do not qualify for federal or state programs, that there be something left at the county level, and the counties have sufficient funding to provide that service. The governor is very clear that he doesn't want to pay for the same person twice, and actually we think that this is a mechanism that abides by that, because to the extent that if immigration reform did get lots of folks covered either now or in 10 or 15 years, then as the number of uninsured goes down, then the state can claim more savings appropriately. But we don't want to take that money prematurely when there still is a large number of remaining uninsured, and frankly, some of this we may not know for weeks or months or even potentially years, depending on some of the triggers in the immigration law as well.
Can I add one more thing, which is that in California we have, earlier it was 10 million immigrants in California who are Latino. I want to just explain that we talked a lot about the undocumented today. We have many individuals in California who are legal permanent residents, and that means that they live in the state. They pay taxes like everybody else. They have the full right to work and travel in this state and in this country. However, they're not yet citizens. And so it's over 3 million individuals in that situation, and our state has not invested in really having outreach and naturalization programs like other states, but moving individuals from LPR status to fully naturalized citizens protects them the most in terms of access to safety net programs, access to health care programs. And so while we talked a lot today about the undocumented, we don't want to forget the legal permanent residents who are now eligible to become citizens and who are not. So there's incredible programs across the state to try to do the kind of outreach, do the application assistance for naturalization, but I really just want to highlight the connection between the acquisition of citizenship and access to health care.
This is Josue. I guess going off of those statements and kind of addressing two questions asked specifically by Michael Cox and Scott Graves, can you expand a little bit more, Anthony Wright, on how the LIP proposal would extend coverage to undocumented folks at the county level? Or is this a requirement, or how would it look like?
Right. So, again, right now, counties have a very vague obligation to cover the uninsured, and some counties take that to mean the undocumented, some do not. So in LA and San Francisco and Alameda, and even in a place like Fresno, it does. But in Orange County, it doesn't. More recently, counties like Sacramento and Yolo and Contra Costa, which had been doing it over the course of last many years, had scaled back coverage. And so the idea is, and there is no specific requirement now of providing that. So then the question is, in this new world, should those counties be locked into what they're doing now, where they were, whether we think that was good policy or not? Some of those counties were deciding that with a very limited set of funds, or the set of funds that they believe they had, that they were directing it to one population. To the extent that that population is being covered, should the state automatically take that money for savings, or should the county be allowed to redirect that money to the uninsured that remained, including the undocumented? We think that if the counties are given the opportunity to continue to use those dollars, not all, but many of those counties would take that. But if that money just gets taken away, then we have no ability to. Then it's a much harder case to make. At the county board of supervisors. So what our proposal does is incentivize counties to cover as many, is to provide to get as many people enrolled as possible. Everybody who presents themselves at an emergency room or a county system would be first enrolled for Medi-Cal or Covered California or whatever was eligible to them. But two, it would incentivize them to sign up people, including those people who are not eligible for ACA type coverage, because then they would get a match. They would get a reimbursed for those services. And three, it would incentivize those counties to try to provide not just episodic and emergency room care, but primary and preventative care to really be more efficient with those dollars to provide